Fantastic. Thank you very much.
Dr. Houlihan, would you mind just introducing yourself so
Yes.
that everybody will be on the same place when you begin?
Of course. So firstly, thank you very much for this opportunity to present to the Barrow Neurological Foundation. My name is Lena Mary Houlihan. As a background, I am an Irish neurosurgical resident who has been attending ASU and in the BNI under the stewardship of Dr. Mark Proul in the Loyal Edith Davis Research Laboratory. My specific area of research has been in transorbital surgery, as well as looking at quantitative neuroanatomy metrics. And that is a whistle-stop tour of what I will be giving today. I will share my screen. I have a presentation here, but please at any time, if anyone wishes to stop me, please do. And I hope that everyone can see the slides. Very good. So the title of my PhD dissertation, which I most recently actually completed my defense on the 1st of September, was with respect to transorbital skull base surgery, looking specifically at the exploratory quantitative anatomy, the microscopic and the endoscopic surgical corridor. Dr. Sarah was very helpful in the comments that he said, as in what I should be hoping to achieve or communicate to the committee over this short presentation. The keys being what was trying to be achieved by the research that you all were so generous to fund, the methodology that was used, and did we succeed in identifying results with respect to the research questions that were put forward. So I have no disclosures. The funding of this research was from the Newsom Chair, Dr. Mark Proul, as well as with gratitude to yourselves from Barrow Neurological Foundation Grant Award. As a little bit of background, what is transorbital surgery? Well, the most gross and gruesome thing that people think of when they think of transorbital surgery would have been Freeman's lobotomy in the 1950s, but the surgical procedure itself dates far before that, even to the 1870s, used by ophthalmologists, as well as neurosurgeons and skull base surgeons, with an aim of getting to the deep orbital region, as well as intracranially. And while it developed a significant stigma in the 1950s, it has now evolved within the early 2000s and late and the 2010s, 20s, to becoming one of the most novel and in vogue skull base anatomical approaches. And this has been facilitated by visualization methods, such as use of the endoscope, which for those who may not be aware, is a fiber optic rigid tube, which has been used in multiple different areas of medicine, from GI to lung to skull base and neurosurgical. And as well as our microscopic techniques and instruments improving. And this has all led us to provide surgical interventions which are more minimally invasive and provide better surgical outcomes. And what are the benefits of a transorbital corridor? What is the meaning, first of all, of a transorbital corridor? A transorbital corridor meaning preservation of the orbital rim and insertion or doing a craniectomy or a bony removal in the roof of the orbit to gain access to the intracranial structures. The benefits are, it's a small incision, which is cosmetically satisfactory. There's minimal destruction of the skull base, both the anterior and middle, depending on your key pathological region. It provides you with impressive surgical operative corridor compared to open cases, and it allows you to get to neurovascular structures. It also promotes a more multidisciplinary input when it comes to skull base surgery, which has been evolving in the recent 10 years with respect to, instead of it being isolated specialists, it's the coming together of ophthalmologists, ear, nose and throat surgeons and neurosurgeons to provide a more multidisciplinary and generally a better standard of care. And finally, it provides us access to multiple compartments through, as I said, a small approach. This is data from a paper that I recently had published in World Neurosurgery in August, which was featured as one of the top papers of the month, where we did a review article of the transorbital work that had been completed this far. As you can see, the numbers have been increasing systematically throughout the years. In addition, from a surgical success perspective, it has been identified that cure rate for cerebrospinal fluid leaks, or one of the most common pathologies used here, would be 93%, which is extremely beneficial when compared to an open morbid cranial approach, which can have significant surgical morbidity, or even an endoscopic endonasal approach, which again uses the scope as a method of visualization, what goes in through the nose and can be destructive to the nasal anatomy. Again, it has had positive surgical improvement with regards to neurological outcomes, such as weakness in the eye and protrusion of the eye. And in general, the complication rate has been overall pretty reasonable compared to its predecessors and its comparatives, be it endonasal or open cranial, really looking at either a recurrence of the CSF leak was the reason that we were providing the operative intervention to begin with, and a very low rate of infection. So what I hope that data has shown to you is that it is a surgical operative corridor that is gaining momentum and is gaining interest in the neurosurgical world. And then moving on from that, when I looked at my own dissertation work, the question was, is it simply the endoscope that should be used? There would be a lot of purist neurosurgeons who would feel that the microscope should also be used with respect to these approaches. And they both have their advantages and disadvantages, be it two-dimensional view of the endoscope versus the fact that the microscope is not able to look around corridors. And sometimes the quality of the visualization is not as crystal as with an endoscope. So the aims and the hypothesis then that were the cardinal views of my work, and there was more on top of this, but these were the two crystalline aims with my PhD, was number one, to see if the use of the microscope as a method of visualization was feasible for a surgical access corridor, which could arguably be seen as the smallest one available at present, as well as then using quantitative analysis to look at a trajectory comparable craniotomy, which would be a superorbital craniotomy, and then looking at the transorbital approach with a microscope and an endoscope, looking specifically at the anterior cranial fossa and paramedian structures. With respect to the quantitative analysis, I have not gone into it in this presentation, but Dr. Prull's lab will be at the forefront of quantitative anatomy, namely using a stereotaxis or 3D coordinate systems, which are used in real-time clinical practice, i.e. neuronavigation on cadaveric dissections. And what this has allowed us to do is it has allowed us to take anatomy from the descriptive model into quantitation with respect to surgical corridors, and giving an objective metric of which surgical corridors are superior to one another, specific to surgical targets. And while there were some metrics out there, what I noted during my own work was that there was a significant amount of heterogeneity as well as a lack of standardization within the literature. And this, because of work that I completed with my husband, who's an engineer, has allowed us to come up with the first standardized volumetric 3D analysis method for assessment of surgical corridors. And this has been patented. The non-provisional patent has actually been filed by BNI on September 11th. And what we hope to do with this, and we have actually put a grant further into this, is to produce the first ever online user quantitative database that allows for these various metrics to be used by all neurosurgeons or by all surgeons who aim to do quantitative anatomy with a view of surgical specific target structures and assessment of those metrics. So firstly, the key operative steps with respect to completing this surgical corridor with the microscope was identifying the pathology, depending on the amount of degrees required for surgical target structures, and completing a superior lid crease incision, which can now be seen here along this region. So the identification of the actual superior lid crease incision allows for it to be cosmetically satisfactory, with your borders being identified, namely the frontozygomatic suture laterally becoming the frontosphenoidal suture medially, and also identification on the lateral aspect of the supraorbital fissure, which is the entrance point into the orbit from the intracranial to extracranial structures. Identification medially is the landmarks of the ethmoidal vessels, which were all visibly visualized using the microscope, as well as our ability in the most deep portion to identify the insertion of the optic nerve. It was also preferential using the microscope to get an anatomic view and more of a panoramic view when looking at the actual craniectomy defect that was completed. And then moving to the deep intracranial structures, what you note is that in all of these images in the bottom right-hand corner, you can see a little portion of white. And that white shading is the supraorbital fissure. And while access to the optic nerve, the ipsilateral paraclinoid ICA, and various anterior cranial fossa vasculature is accessible, there is significant hindrance from the from the orbital rim because of its persistent presence and the fact that it has not been removed. And this again can be seen here in the fact that even though we can see more medially to the anterior communicating artery complex, which is a midline structure, this cannot be accessed with instruments because of preservation of the rim. So the limits, as I've described, there's contralateral exposure with this preserved model is not accessible. There's poor access to the planum sphenoidale, and because we are working with the orbit, even though dynamic retraction does allow for less pressure on the orbit itself, the instruments do need to be removed every 15 to 20 minutes. The advantages, as had previously been described. So from a neurosurgical perspective, is the microscope a method of visualization that is warranted? Absolutely. And when we come on to the next level of this work, we can see why the microscope would actually be preferable in some circumstances to the endoscope. This was the result of comparing a superorbital craniotomy, which is a craniotomy that can be completed above the eyebrow, and it takes off about a 5 to 6 centimeter cranial bone, and then allows you to get deep along flush with the anterior cranial fossa. However, with this kind of a craniotomy, cosmetically it can be unsatisfactory, as well as this, sometimes you end up taking off more bone laterally than will be required, leaving again some cosmetic deficits. So looking here at the three approaches, which was the supraorbital, the use of the microscope, and the endoscope, there was hindrances moving more medially, as was to be expected with the various structures. But again, it was noted that the endoscope was more hindered, likely because of issues with surgical crowding or crowding of the instruments, because the endoscope goes into the cavity as well as the maneuvering instruments themselves. Looking again at the various target structures that we had looked at for this project, we have the paraclinoid ICA, terminal ICA, which are various portions of the carotid artery, as well as the anterior communicating artery, this midline vessel, which we would aim to access. And what is evident here is that, again, the more midline vasculature was impaired compared to the more ipsilateral vasculature. And again, more so with the endoscope than with the microscope. Angle of attack is a metric which we use to assess how much ability we have for movement of our instruments. So cranial caudal, superior, inferior, and mediolateral from midline to the most lateral aspect. And here, just as a general summary, the paraclinoid ICA was statistically significantly superior when use of the supraorbital craniotomy, which is not unpredictable because it is a greater sized craniotomy and a larger defect. But also when looking at the transorbital microscopic approach, there was actually statistically significant superiority in the mediolateral aspect, again likely attributable to surgical crowding. This can again be seen craniocaudally with respect to the terminal ICA. And interestingly enough, when it came to the anterior communicating artery, there was no statistically significant difference between all three approaches. When looking at volume of surgical freedom, which is the metric that was established within our lab and has been published in a peer-reviewed engineering journal, again, we were able to see that the paraclinoid ICA was better accessed through an open craniotomy. But again, if one was to try a transorbital approach, the microscope would be superior in accessing with respect to whole three-dimensional volume. And again, this was also seen with respect to the microscope accessing the terminal internal carotid artery. And interesting enough, when it came to the terminal ICA, there was no statistically significant difference between the supraorbital approach, the larger cranial access corridor, versus the microscope. Understandably, when it came to medial access, the supraorbital approach was far superior because one was able to gain, we hypothesized, more lateral access. With regards to statistically significant difference between the microscope and endoscope for the transorbital approaches for that surgical target structure, it's difficult to appreciate because we are dealing with such small numbers, given, as I previously showed, the difficult hindrance. And then just to show how this volume of surgical freedom can be translated into imaging, which we can now use morphologically to show our surgical target structures and the surgical corridors which are produced. Up to this point, we were not able to produce a three-dimensional view of these surgical corridors. And as you can see from looking at the supraorbital approach and the microscopic approach, we have a panoramic external view. So that's why here it is more figurative morphology with respect to the actual approach, as opposed to with the endoscope, when your method of visualization is within the cavity and therefore your actual corridor still includes your actual endoscope. And these are some other examples of models that we have been working on, which we are quite proud of, because they do provide the first ever three-dimensional model of an objective metric that allows you to get surgical corridor access of not just the craniocaudal and mediolateral angles of attack, but the whole morphology of the structure with respect to spatially and anatomically accurate parameters. Very briefly, because I know I'm over time, as we said, the supraorbital craniotomy was larger in all parameters, but it is also a more invasive surgical intervention. It's more cosmetically inferior, and there is more lobar retraction, and it can cause a skull base defect, as opposed to the benefits which have previously been described with the transorbital approach. So in summary here, supraorbital approach was larger with respect to parameters, but the transorbital microscopic approach does have benefits with respect to different surgical target structures, namely to the paraclinoid ICA, as well as in the surgical freedom of the terminal ICA. Ideally, it looks like, with respect to the anterior cranial fossa and paramedian structures, a combinatory visualization strategy would be preferable. But when it comes to instrumentation utility, the microscope appears to be superior with respect to your actual maneuverability. I would like to acknowledge my PhD committee, as well as the fantastic people within the lab. And it does take an army to do these kind of measurements to the scientific validity which is warranted for these kind of papers. I would like to thank ASU for this phenomenal opportunity, as well as Dr. Pruill for this phenomenal opportunity. And thank you all again for supporting this research, which is incredible to have such support, and I'm greatly appreciative, and I welcome any questions.
Thank you, Dr. Houlihan. I have a quick question. Do you think that practitioners of supraorbital surgery, given the value of the alternative that you've shown, are likely, I mean, is the training to do the kinds of corridor manipulation that you've described here rigorous enough that it would be a challenge for practitioners of the supraorbital approach, and are they likely to adopt the kind of approaches that you've described, either microscopic or endoscopic?
Yes. So the reason the supraorbital approach would be considered one of the mainstay workhorses of a neurosurgeon to get to the anterior cranial fossa, but it would be very exclusively used in very specific pathologies. So I think the best answer to that question is what is the most suitable corridor specific to the pathology. So if one was trying to get to the midline area and get good midline access via an open craniotomy, and there's multiple ways to get to the midline, depending on what pathology you're dealing with. You could go either midline up through the nose, and one of the other papers that I've completed here really does say that there is, if we were trying to do a bilateral transorbital approach, there is no benefit in attempting that because you don't have the lateral access warranted for benefit. But it is a case of if one was trying to get to the anterior communicating artery for an aneurysm clipping, and this was one of the questions that Dr. Lawton had put to me, a transorbital approach is not appropriate because it does not give you any of, it's severely inhibited and it's dangerous, and you don't have the distal and proximal access and security that you should need. However, if one was trying to get to a more ipsilateral region, for example, the sphenoid ridge, which can be drilled down, which is at the posterior aspect of the orbit, or as has been shown in the quantitative analysis, the terminal ICA, which shows comparable surgical maneuverability, then that certainly would be a surgical target that should be considered through a transorbital approach. I think that a lot of neurosurgeons have had hesitancy with the orbit. It's been driven in historically that the orbit is almost a no-go region, except for Dr. Spetzler, who did a lot of work with larger craniotomies that involved the orbit. But here we're trying to go for more minimally invasive and less destructive. And it is really tailoring it to the approach. So actually one of the projects that myself and Dr. Lawton have considered is now that we have viable data showing that the terminal ICA would be a reasonable surgical target structure for a transorbital approach, and both with the microscope and with the endoscope. And there really is this thought of what people have been taught with the endoscope or the microscope, or you can't do both, when in reality, being a skull base surgeon, you should probably, in my opinion, be able to do both. And what Dr. Lawton and I are going to do is hopefully take a retrospective analysis of all of the terminal ICA aneurysms in BNI with an aim of looking at their actual morphology. And we're